available for everyone. Or you send teenagers to these school programs. Rather that, right? I think it's still in programs. I'm not sure if it's available as such. You also have to get the adolescent ones. Huh? You cannot do it in elderly women. Okay, so you see here what's happening on that side. They're already, up to last year, 6 different vaccines available worldwide. And the newest one is this Gardasil, the nonavalent one, which is really covering 9 oncogenic types already. Okay, so we are really also increasing the scope we are covering. Huh? You see here in Kenya, these 2 types are available. One is only bivalent, is only covering 16 and 18, but I should not say only. Huh? They are the ones causing cervical cancer in 70%. So that's also good enough. And then you see Gardasil, the quadrivalent one, is covering also 6 and 11, which are not the oncogenic one, but still, they can cause these genital warts. So now this very newest one, who is covering 9 types, is actually covering these 4 types, 16, 18, 6, 11, but now you see also this other one, 31, 33, 45, 52, and 58. So which is nice, and I'm sure it will also come into African countries. The protection rate of these vaccines is excellent, nearly 100%. And so far also when you check the antibody response, it's so good, so high, that we already know it's for 12 years you are covered, that we already know. Maybe then in 8 years we know that you have a good protection even up to 20 years. And so far there's no recommendation for boostering, and side effects are really minimal. And you see now here, WHO, Kenya is not really exactly the same, but usually we vaccinate girls before they become sexually active in the age group 9 to 14. That's worldwide. In Kenya, it's up to 13 years. I don't know why. And usually it's done still with 2 shots, but WHO is already recommending only 1 shot because the efficacy is so great. And the ones who are a bit older, then they need 2 shots. In the program is still 3, but I'm sure it will change into 2. Only if you're immunocompromised, you still need the 3 shots. So if you have an HIV positive woman, maybe you do 2 tests, HPV negative, she wants to have the vaccine, you can actually give it to her if she pays for it, and then you need the 3 shots. And you see how you have to give it. And by the way, also many countries already also start vaccinating the boys in the same age group. All right, and now secondary prevention. So what can we do once somebody is infected? How can we still prevent cancer? Because really the time is a little bit advanced. I will not go so much into details, but I want to show you there are guidelines, Kenyan guidelines. They're already a bit old, from 2012, and they're the newer ones from WHO from 2021. So in between, of course, WHO has collected a lot of data from cohorts and so on, and adjusted their guidelines. All right. So this is nice to see quickly, these 3 tests, which are widely used, to see a bit the comparison between the tests. And I'll let you read a little bit. You see that the conventional cytology, which is called pap smear, is already used more than 50 years, so we have a good knowledge about that. But you see the sensitivity is not even so high, only up to 62%. So the via Willi actually is much better, up to 79%. But then the specificity is not so good. And as Catherine said, still you need somebody, to be really trained to understand how to use these different solutions correctly, how to do the interpretation correctly. And now you see that in the middle, HPV DNA test, a wonderful sensitivity. So it's the most sensitive test, and the sensitive a test is, the less likely you have to use it again, okay? If a test is not very sensitive, then much more you have to screen a patient again and again and again, because you don't want to miss the disease. But once you're using such a good test who has a sensitivity of nearly 100%, you don't have to do so many screenings. And that's the huge advantage of this test. And also that it's an objective test. And you see that the screening intervals still used quite broadly is actually like that for HIV negative one, you do a pap smear every 5 years, for HIV positive one every year. Same for the Via-Vili. But now the big question is HPV. How will it change? How do you do it? The ones who are using HPV PCR testing, how do you use it? Let me say the test is negative. You start with 30 and then the test is negative. What are you doing then? When is the woman supposed to come back again? After 2 years. Okay, that's quite soon again. So I found it interesting that in theory, everything is already there in the Kenyan guidelines. But when you look into practice, we are not yet doing what they already wrote 8 years ago in 2012. So they already said it would be good actually to do this HPV test. When it's negative, you can rescreen after 5 years. If it's positive, you do a Via-Vili test. If that one is positive, of course, you follow that flow chart to treat then that woman which has a special lesion there. But if the Via-Vili is negative again, you can do the rescreen with HPV when they are HIV negative and after 6 months when they are HIV positive. So these were the guidelines from 2012. Of course, since then, we have gathered a lot of new information and data, and even also here in 2012, the guidelines said that currently it's recommended every 3 to 5 years to do the test, but intervals will be investigated. And Catherine already showed you the WHO guidelines from 2021. So the first guideline for the general population, but also for HIV positive one, you see now is they recommend using HPV DNA detection as the primary screening test rather than any other test for both normal population, HIV positive ones. And for the general population, you start using this test with 30 years, when a woman is 30 years old, and you can stop it when she's 50, especially when 2 tests consecutively were negative. For HIV, we start a bit earlier, with 25 years, but we also stop with 50 years if 2 tests are negative. And the new approach I mentioned before is actually that you're not just doing a screening test and you treat immediately. They say now it's better to do screen, triage, and then treat. And the triage is just a second test. And Catherine already showed you the algorithm. I also chose this one. There are 7 different algorithms. So WHO is still open that you can use all the tests available, but you should always do 2 tests before you start the treatment. So that's the new approach. And I have chosen this one there because, first of all, we have the Gene Expert machine. We are planning to test HPV DNA, so that's available here in Jalaram. And then cytology, the pap smear, we're already doing it as a routine. And we have the lab and we have Dr. Rao, our pathologist. So because we have all the setup, we will choose this algorithm. And it's really a nice one. It will really reduce a lot all these screenings because HIV positive women should be screened every year. Okay? And others every 5 years. And when you look now, if the HPV DNA testing is negative, you can then rescreen a woman who is HIV negative all 5 to 10 years. And if she's HIV positive, you do it just every 3 to 5 years. You see? You can do 1 test and then avoid 4 or 5 additional ones every year in an HIV positive woman. So I think that's really excellent news, and it's even more sensitive. So we really find out the problem with this test much quicker and much accurate than with other tests. If the test is positive, you see, now the triage tests here now in this algorithm would be that cytology. So the pap smear would be that second test in that algorithm, and that will help them to differentiate. Can somebody also follow the follow-up screenings every 3 to 5 years, or does he has to undergo a coloscopy and maybe a biopsy, and then decide for treatment. So that's really what I wanted to share with you, because I believe this is the future, and I would like to start doing that with my HIV positive women, but of course with every woman coming to us for a screening. And how do we do this HPV DNS test? I mean, Catherine has showed it to us. You can just use the same machine. You see that is the cartridge from TB, which I showed you before, and then you just need this other cartridge, and that's it. You use the same machine. And this PCR, which we will validate with Catherine, will detect at least these 3 oncogenic types, which are causing most of the cervical cancers in women. Here, just very quickly, that you see, these are all the options for treatment, nothing new about the treatment. And for you now, that's what I want you to keep in mind. These type 16 and 18 causing more than 70% of the cancers. How can we do the prevention? Primary prevention, vaccination, second prevention, really do a close cervical cancer screening and start using HPV DNS testing. That will be the new gold standard, I'm quite sure about that. Okay? But we are now somehow in a transition time, and that's also why WHO still gives you all the different versions how you can do it. Huh? But still, the recommendation is clear. The first screening test should be HPV DNS testing. And we start in HIV negative ones with 30 years, HIV positive ones with 25 years. And then if the test is negative, you can do it every 5 to 10 years or 3 to 5 years, HIV positive or negative. All right, so that's what I wanted you to know. And of course, that we will start doing this, and I will let you know as soon as we start. Okay? Catherine?
Yes, I have a comment maybe to us as clinicians. So you find most of the time when your patient visits you at your CCC, they will not ask for the test. Very few of us will ask for the test, even me, who was going to school. So it is up to us as clinicians to recommend the test to the patient. Otherwise, they never ask for it. And we keep on missing these cases in our facilities. So recommend the test to patients. Just ask them if they've had a HPV test before. Would they like to have it, and explain the benefit of taking the test to them.
Yeah, thank you for this. And you know, waiting for 1 month is also a bit long, right? Yeah. So how long does the test really take? 90 minutes, right? 60 minutes. 60 minutes only, okay?
Just 1 hour.
So for sure, we will report on the same day, huh? Like we do really for sputum. If I send a sputum in the morning at 9 o'clock to Dr. Rao's lab, I have the result at 12 o'clock. The patient waits, we have a nice cafeteria, and after that he comes and sees me and I start the TB treatment. Huh? Same then also for HPV, because the easy situation is HPV test is negative, right? Then you just have to book for the next test. But if it's positive, then you know, a cascade of other things has to be done. And that should then be discussed with your patient. All right, I think we are coming to an end now. Is the tea served? Okay, so you can really go and have a cup of tea. But before you're leaving, I just want to know, do you have any questions, anything you would like to know before we close? Okay.
How much do you take for HPV?
We have not yet started. Yeah, but I will share the prices, even also for HIV viral load, because I think that could also become important for you guys. Because I see so many patients for review, and none of them has HIV viral loads. I don't know why it comes like that. 3-4 years, nobody has a viral load. So I think if HIV viral load testing is also available and cheap, I think you will also send more patients to do it, right? Yeah. So yeah, HPV, it will come. I will let you know. Yeah.
For those cases that turn HPV positive, you're supposed to refer them to do colposcopy, which we don't have in our facility. So, in the future, do you think as you come up with HPV, you still have the colposcopy?
Yeah, sure. You need it. You need it for the ones, you know, are positive. And I haven't shown you the other algorithm because you are also, of course, allowed to use this algorithm. You see, you do first HPV testing and then via Willi. You see? But if that testing is also positive, then you have to go further and check and start also the treatment. So I don't want to use this because you see we have Dr. Rao and he can really nicely look at the pap smear, so we are using then this one. But you see, colposcopy is still there. Because without that, you cannot really do the treatment. And in some patients, you might still need a biopsy first, before you start treating. So that's helpful.
That's basically when you're doing a colposcopy and you are taking a biopsy, of course the biopsy will tell you whether it is just a carcinoma in situ, that is the carcinoma is not going across the basement membrane, it's only HPV. So it's like it's only HPV, nothing much to say about that. And when you, biopsy is of course the 100% confirmation to rule out squamous cell carcinoma of the cervix. But still in a pap smear, I would feel that an experienced pathologist who has seen around 500 cases of slides of pap smear, it's very easy to make it out whether it is a ascus. Ascus means atypical squamous cells of undetermined significance. Then the other one is L-cell, which is more higher than the ascus when it comes to grading a malignant lesion. That is the lower grade squamous intraepithelial lesion, followed by H-cell, which is high grade squamous intraepithelial lesion. And then there is squamous cell carcinoma, that means it is invasive SCC. So it's very easy to find it out in that, but what we suggest is even if we get a ascus, that is the most basic, some atypical cells at a very few foci, then we would recommend for going it for a HPV testing. So HPV is very much required nowadays. It's mandatory. Right now in the NHS, that's in the UK, they have actually married pap smear along with HPV testing. They just don't rely on a pap smear. They just don't rely on HPV testing. They combine both of it and they are doing it. So what they recommend is any female above the age of 30 will go for HPV testing as well as a pap smear every 3 years. So that's the protocol of NHS in UK.
But you see, these are the national programs, because I showed them the WHO guidelines which we can really adapt when you have limited resources. So this is what he was talking about. There are these different type of how you can categorize, how you say it?
The categorization of the pap smear,
yeah. So there are these different terminologies.
We follow the Bethesda system,
which
is used to grade the carcinoma cervix.
Yeah. This is the ones usually used.
So ascus, agus, L-cell are all low grade ones. When it comes to H-cell, that it means it is going to a high grade one. Yeah. And then it goes to CIN1, CIN2, CIN3, and the fourth is invasive squamous cell carcinoma.
Thank you very much. Other questions? All right, so then thank you very much for your attention. Thank you. Oh, there's a question? Yeah, sorry.
You said that condoms rarely prevent against
No, I didn't say rarely. Of course, condom use are really protecting against many STIs, but unfortunately not 100% against HPV. Okay, because HPV is not only transmitted through all the body fluids in the exchange when you have sexual intercourse, it can also be the contact skin to skin. So that I wanted to mention. Any other question? All right, then I have a last one before you can go and have your cup of tea. How did you like this setup? Because for us here, it's the very first time we have clinical officers in this room. I hope you're aware. You're a very special audience for us today. Usually we do CMEs, but for internal and external, but then doctors are invited. So how do you see that? Did you like today's sessions? Okay, would you like to hear more topics? Okay, because then I would see with the coordinators that we can really do that. I don't know how many times you have CME, once a month, once every 2 months?
Once a month, and I think the time should be at least 3 to 4 hours.
Really? So long? Yeah. I thought next time I would do it a bit shorter, because this was a whole...
Do you hold meetings?
Okay, I'm saying, okay, I'm suggesting that if you can have a monthly CME, but it should be for 3 to 4 hours. You can have a good time for discussion.
All right, I found it rather long. If you look at this now, we started at 1 with the lunch, at 2 we start with the presentation, now it's 4 o'clock. You are sitting now 2 entire hours here listening. You even want to listen more. No, if it becomes a routine, I would really start doing that for you. You are even invited to give me the topic. And we always see a little bit with which partner we are doing it and even which topic. You know, sometimes I can also bring another specialist in. But basically, I would run the show and you are telling me which topic. Is that a deal? But you honestly want to listen for 4 hours? Exactly. 2 hours is okay, right? Actually, this is very long because we did a lot of introduction. We wanted you to understand where are you, in which facility. Yeah? That's why you heard the CEO talking. And I wanted you to get to know me and my clinic. That's why I introduced it. But from now on, you know us now, right? Now we can just focus the topic and question and answer. Everyone agrees on that? 2 hours, one topic?
Yeah.
The majority, huh? All right, good. Thank you very much, really, for your attention and for your coming. Please just go out and serve yourself with the tea. And then we have the deputy sister in charge. She will lead you then down to the exit, just by walking you from one floor to the other so that you see what we have. Is that okay? Okay, so then please collect my card so that you also have my telephone number. It's also WhatsApp, it's my business number, so you can contact me. Also take the flyer from our facility because you see all the specialists we are having. And of course also this one. Huh? If you're interested in more knowledge about the Gene Expert machine, please take this also with you. And then let's have tea. Okay? Do you want to say something?
Well, just saying thank you for coming. And also his message. Yeah. Well, I think it's 2 times, so there is no good one. And so thank you for coming. My name is Dr. Victor, and I'm the new medical director for RKGMS. Please feel free. There's tremendous experience in this building. If you need any form of consultations, you create for us so that will happen. You're welcome. So, karibuni sana. Thank you so much.
Thank you. They're clapping, you see.